Good morning, everybody, and today you will be talking on Meniere's disease. Many of the information included in this presentation comes from this very good book by Rockenstein, published a few years back. It's really an excellent book dedicated to Meniere's disease with in-depth analysis and review of the literature and highlighting different aspects of Meniere's disease. We'll start with the question. Is Meniere's disease understood? No. Any other answers, or all you agree that is Meniere's disease not fully understood yet? This is another aspect. So there is no consensus in understanding of Meniere's disease, and that's true. So why it is difficult to understand Meniere's disease? In the presentation, I will use MED as abbreviation for Meniere's disease. There is many reasons why we cannot understand Meniere's disease in a very good way. First is the low incidence and prevalence. Second, the difficulty creating complete animal models. Third is the difficulty obtaining pathological human specimens. And fourth, lack of valid measurement of disease severity and treatment efficacy. And lastly, the natural history of the disease toward this improvement. So because of these factors, it's really very difficult to understand Meniere's disease. History is still written because we didn't get to a final and complete understanding, and we didn't reach it a very clear and evidence-based approach for the management of Meniere's disease. Still, we have to work hard as clinicians and researchers to fully address Meniere's disease. Prosper Meniere was accurately described the disease and anatomically localized it to the inner ear. Before Prosper Meniere, nobody knows that the inner ear is responsible for vertigo. And so it's some sort of cerebral condition, and it was a very fixed belief at the time. So he came and proved that the vertigo comes from the inner ear, and he very accurately described the presentation of Meniere's disease. Holbein and Cairns, in 1939, they did a very good work. And their studies showed that they found saccular and endolymphatic space dilatation, and hence they call it endolymphatic hydrops. And the first two cases they studied, there was two patients, they tried to do vestibular neurectomy for them, and both of them, they died because of the complication of the surgery. So they did examine their temporal bones, and they found the endolymphatic hydrops. And they proposed the theory that is increased hydrops can origin from increased production of endolymph or alteration in its ionic homeostasis. The increased endolymph will increase the pressure, causing asphyxia of the inner ear structures, causing hypofunction and the acute attacks. And they believe that acute attacks mainly associated with hypofunction rather than hyperfunction or irritation. So when you look to the literature or you read any articles about the histopathology and the pathophysiology of Meniere's disease, you have to keep in mind that is the ideal disease process which we can believe in it or accept it as an efficient model should be able to explain the reversible cochleovestibular dysfunction occurring with Meniere's disease, and could be able also to explain the permanent cochlear and vestibular loss which can occur with Meniere's disease. And disease process have been in the literature explained in different theories, like the ototoxins, like the viral immune-mediated small neuroma of the vestibular nerve, genetic mutations, channelopathy. So there were many theories of Meniere's disease, but no one perfect theory. So in the next few slides, we'll talk about the famous theories on Meniere's disease, and all of you familiar with Schoenstatt, and what he thought about Meniere's disease, that is, because of the effect of fibrosis and the swelling, there will be obstruction of the longitudinal flow in the endolymph pathway, leading to building of pressure in the swollen endolymph system, which causes rupture of Reisner's membrane, allowing mixing of endolymph with perilymph content, which causes potassium intoxication, and the presence of potassium in the perilymph will cause acute dysfunction of the sensory hair cells, leading to the symptoms. Then the release of the endolymphatic pressure will permit healing of the membrane, leading to return of the normal fluid homeostasis and cessation of the symptoms. And this cycle of events explains the episodes. Unfortunately, the work of Lawrence in 1966, they reported that is the regulation of endococcular fluid volume is controlled locally via radial flow of the endolymph through the perilymph and recycled back to the scala media via the spiral ligaments and stria vascularis. So they proved that is the longitudinal flow is not an important factor in the homeostasis of the endolymph. So this was against the theory or the explanation by Schoenstatt. So the whole landmark of histopathology is endolymphatic hydrops, but endolymphatic hydrops is not enough to explain the whole disease process. So they thought, or Rockenstein in his book concluded that the endolymphatic hydrops is mainly an epiphenomena, not the cause of the clinical symptomatology of Meniere's disease. So it's important to differentiate between Meniere's disease and the endolymphatic hydrops, because it was reported that some asymptomatic patients, they found the endolymphatic hydrops in post-mortem status. And some of the symptomatic patients, they didn't find endolymphatic hydrops in the post-mortem status. So it makes sense that we believe that is the endolymphatic hydrops is mainly an epiphenomena rather than the cause of the symptoms in Meniere's disease. Channelopathy is another theory or another pathophysiological model for Meniere's disease. And it's based on some factors. That is the inner ear, it has a wide variety of channels and conductance. It's actually the inner ear is based, its physiology and mechanism of action based completely on active ion transport mechanisms. So ions and the channels could play a role. Also, they found that it's a fact that the mutation in genes that code for the ion channels result in hereditary deafness. Anticipation is observed in other neurological disorders that are caused by channelopathy, such as the migraine. Many patients with the channelopathy are responsive to acetazolamide, a drug that has been proven effective in Meniere's disease. So with these factors, channelopathy could be a potential model to explain the symptomatology in Meniere's disease. But as I mentioned, there is no one 100% model yet. Psychopathology in Meniere's disease. 63% of Meniere's patients, they have dysphoria, like psychiatric problems like anxiety, depression, and the somatization. And Meniere's disease is common to be associated with migraine or vestibular migraine, which are known to be triggered by stress. So let me to ask you, in your experience, so the disease is a unilateral or bilateral disease? In your experience? Mostly unilateral.
Starts unilateral, goes bilateral in my experience.
Good, good, good. So what is the percentage of bilateral disease in your experience? 5? Good. Yeah. 5%.
Low.
Dr. Pradeep.
In a series of 150 cases, I had 8% of cases. 8% bilateral.
8%.
Yeah.
Okay. That matches with.
According to my professor, Jack Mannion, he says that around 28% is the bilateral incidence
28.
average. Because he has almost like 2000 series case series.
Okay, that's really goes with what's written here. There is a wide range of reports. And this is because the diagnostic criteria is different. When you look for literature, published papers or articles, you have to understand many things, at least the criteria, the diagnostic criteria used. Not all the studies, they use the same diagnostic criteria. That's why variability, you can find variability in reporting. The one more thing, that is the duration of the study. If you have a longitudinal study following up Meniere's disease patients, see if how many years they are following, 2 years, 5 years, 7 years, or 20 years. Because as if you follow up the patient more, like bilateral incidence or bilateral disease will show more. One more point, that is the early presentation of Meniere's disease. If the affected subject is younger, so you expect that they most likely they develop a bilateral disease in their life. So it's from 8 to 78% of bilateral affection, mainly because of using different diagnostic criteria. And yes, it's usually starts unilateral, then goes bilateral with time. Diagnostic criteria used and follow-up time is important factors when you read an article about Meniere's disease. Early onset is usually associated with more bilateral disease. Epidemiology of Meniere's disease. So the hallmark or the landmark study, American study, it was a 30 years study from the Mayo Clinic. They reported that the incidence was estimated at 15.3 per 100,000 per year, and the prevalence 218.2 per 100,000. And in the literature, the highest reported prevalence in Meniere's disease is 513 per 100,000. The annual incidence worldwide of Meniere's disease reported to be between 4 to 28 per 100,000. Demographics. So the most common age of affection is 50 to 70. Equal sex affection. Before there were some reports that's more prevalent in females. So what's your experience in India? Yes? Females. Good. Any other experience? In?
So we see them in much younger people also.
In younger people. Yeah. Good. So Dr. Manoj reported it's more common in females and more younger. Dr. Sandeep? Females. Yeah. We'll talk about this.
Yeah, I feel it's equal.
Equal.
Yeah.
Equal. So overall, reviewing the literature shows it's almost equal sex affection. And in 5 to 15%, it's familiar because of autosomal dominant with incomplete penetrance. How frequent you find familiar Meniere's disease in India? Is it common to have families with Meniere's disease or not much? Not much. Good. The more prevalence in females or more affection females, it was many reports came before having a definite diagnostic criteria for vestibular migraine. In our experience, the most important differential diagnosis of Meniere's disease is vestibular migraine. And before 2013, we didn't have a formal entity, a disease entity labeled vestibular migraines. And many of those labeled as Meniere's disease, most likely they did have vestibular migraine. And as we know, migraine is more common in females. This could explain the controversy in the literature. Clinical presentation, most of this points have been reported by Prosper Meniere very early when he first reported the disease. So it can show vertigo, tinnitus, hearing loss, drop attacks, chronic low-grade disequilibrium, waxing and waning or fluctuation of the symptoms, and the low frequency hearing loss. And low frequency here means less than 2,000. Sorry for the mistake. It's less than 2,000 hertz frequency. It can show upsloping sensory neural hearing loss, inverted V audiogram, or eventually a flat configuration. So usually start by a low frequency hearing loss or a V-shaped, inverted V-shaped hearing loss. Then with progression of the disease, the hearing loss becomes flat. The hearing loss can be of mild, moderate, or severe degree of sensory neural hearing loss. It's rarely that Meniere's disease progresses to a profound degree of hearing loss. Total hearing loss is rare. And if you have a total hearing loss, you have to think about syphilis or immune-mediated inner ear disease or genetic diseases. Dysplasiosis and the sound intolerance have been reported with Meniere's disease. Vertigo usually burns out without surgery within years. So this is the thing. So those are examples for the common audiometric configuration in Meniere's disease. So like you see, it's here, low frequency hearing loss, and sometimes the high frequencies, they are normal, like this one. Flat, this is almost like flat audiogram. This is the inverted V audiogram. So in your experience, do you have like different audiometric configuration in Meniere's disease, or it's the same? Same, and actually the diagnostic criteria, they put it should be a low frequency sensory neural hearing loss. The diagnostic criteria by the American Academy of Otolaryngology, it should be a low frequency sensory neural hearing loss. Yeah, usually early, then with time it progresses, it becomes flat. With recurrent episodes and the time, usually it progresses finally to be flat sensory neural hearing loss. Yes, we'll explain about the ear pressure. It's just one of the important points to understand about Meniere's disease is the natural history, because that will help you to proper manage your patients. So the natural history of the disease, that in majority of the cases, the vertigo will be burned out by almost like 7 years. And the fluctuation will become less, and the hearing loss become flat and to a great extent stable. I found in the literature what Shia published, that it's some sort of staging system for Meniere's disease, which have been published 1993. But what was interesting for me, if you look here, really, it's almost explains the natural history of the disease. So at the beginning, you have fluctuating hearing loss, tinnitus, oral fullness. Then at the end, you have like a profound hearing loss, and the vertigo goes. So from this simple table published by a great surgeon, it gives an idea about the natural history of the disease. Nystagmus in Meniere's disease. Maybe we mentioned yesterday that in our experience, and I think also in the literature, that most of the cases, they show only horizontal, especially for the spontaneous attacks, the nystagmus is always horizontal. But in Meniere's disease, you expect like secondary benign paroxysmal positional vertigo, because BPV can occur in association with different otological disease, and it's more common. Its incidence increases in patients with Meniere's disease, so it's not uncommon to have a secondary BPV in Meniere's patient. And if you have BPV, you could have a different kind of nystagmus, upbeating torsional of if the posterior canal affected. But for spontaneous attacks, the nystagmus is always horizontal. And we explained this, and we mentioned that any disease process which causes simultaneous excitation or simultaneous inhibition or a simultaneous hypofunction of the three semicircular canals together, the sum of this will be finally a horizontal rotatory nystagmus, because the vertical components of the anterior canal and the posterior canal will cancel each other. So do you have a different experience or the same experience? Same, yeah. So in spontaneous attacks, it's always horizontal nystagmus. Direction of spontaneous nystagmus in Meniere's disease. This is one of the interesting topics in the literature, because they mentioned finally that is the spontaneous nystagmus in Meniere's disease does not determine the site of affection. And they explain this because it can be from irritative phase or from irritation or hyperexcitability in the affected ear, or it can occur because of the hypofunction or because of the recovery process. So what is the recovery process in a disease with waxing and waning? With episodic like hypofunction will occur, then this hypofunction will recover, which means it will improve, it will restore its function. With any unilateral vestibular hypofunction, immediately the brain reacts in hours immediately and start doing what's called physiological vestibular compensation. So immediately it will do actions to compensate for the unilateral function. So these vestibular compensatory mechanisms like will work on the vestibular nuclei level, will work on the cerebellar level. So it meant to balance the discharge at the vestibular nuclei level. So it's like it strengthens the weak side. So in just in few days, that weak side restore its function. So the affected ear afferents will have restored their normal function, and at the same time they have more strength because of the compensatory mechanisms done by the brain. So that's why they become more stronger than the normal ear in the other side. And from here comes a reversible phase of nystagmus, which is called the recovery nystagmus. Pathologic ear with hearing loss, always you can determine the affected side by presence of hearing loss, tinnitus, ear fullness, and the weaker side in caloric testing. Sometimes you don't know if the patient he has simultaneous bilateral disease. Migraine is most important differential diagnosis, and at the same time, in 50%, approximately 50% of Meniere's disease patients, they do have associated migraine. So migraine can show different types of nystagmus, so that should be also considered. If the patient has a history of migraine, with migraine you can expect any kind of nystagmus. In migraine you can expect any kind of nystagmus. And you have to consider, as we mentioned before, that is the secondary PPV, which can occur with Meniere's disease, can show also other types of nystagmus. Dr. Dursalla and Dr. Pradeep, they published an interesting study about pendular nystagmus in Meniere's disease. And it was a really interesting case report or interesting study. But when I went to in depth in the literature, they speculated an explanation. But when I review the literature, I got another explanation. So it's a more simple explanation, that is the common association between migraine and Meniere's disease. So migraine is the most common central vestibular disorder. So that's why it's, for me, it's more easy to explain by the association of migraine, and so in this case, if they do have associated migraine or no, because it's more easy to explain the presence of pendular nystagmus by the associated migraine rather than by the Meniere's disease pathology. Tumacrine crisis. Tumacrine in 1935 described the condition. It's called otolith crisis. It's caused by acute utricular dysfunction, which causes acute loss of the extensor tone via vestibulospinal pathway, leading to fall without loss of consciousness. So how to differentiate the Tumacrine crisis from loss of consciousness or fainting? And just no loss of consciousness. It's just a sudden loss of balance. So the patient fall down to the ground without loss of consciousness. It's reported to occur in 2 to 6% of Meniere's disease. So in your experience, how common is Tumacrine crisis in Meniere's disease? Not frequent. Yes, yes. Yeah, it's rare. Yeah, sure.
Some studies report that these otolithic crisis phenomena occur in the later phase of the disease, in the later stages of the disease. And some other studies say that it can happen any time. So what's your experience? Can it happen in the early phase?
We have, like in our series, we have like 3-4 cases among, I think, like 200 cases. They experience Tumacrine crisis with different severity, but one of them, she was a lady, and she has really very frequent Tumacrine crisis with repeated falls, with many fractures caused by the falls. I think it wasn't late in the disease, just was like after 2 years from the onset of the disease. But because of the very few number of cases, we can't give accurate reports. But this was our experience. And for that lady with very frequent Tumacrine crisis, immediately we did the intratympanic gentamicin injection, because that changed our strategy, management strategy, because that's something life-threatening and something disturbing her life quality. We can't be, we have to interfere in an effective way. And she fully controlled after the intratympanic gentamicin injection. Yes. What? I can't hear.
Did you consider catatonia in that particular patient who was having that many number of drop attacks?
What?
Catatonia. With that number of...
I started my life as a neuropsychiatrist, so I know catatonia. But no, she has a full picture of Meniere's disease, and she was investigated in different aspects. She has very typical Meniere's disease. Thank you. Hennebert's sign, it's always written in the classical text box. So if you do a pressure or tracheal pressure, or you pump pressure into the external ear canal, patients will experience vertigo and nystagmus. It's easy to explain in cases of perilymphatic fistula, but for Meniere's disease, there was some explanation, that is the vestibular fibrosis between the utricular and saccular macula and the undersurface of the stapes foot plate. That was the reason why, with the pressure changes in the external ear canal, you could get a positive Henneberg sign and fistula test in Meniere's disease. Ear fullness, Dr. Ahmad was asking about the ear fullness in Meniere's disease. And really, I didn't know a good explanation for the ear fullness before I started preparing this lecture. So inner ear is not a senate structure. There is no receptor to sense pressure changes or other pain or something in the inner ear. So where comes the sense of ear fullness? So the explanation was that it's a learning from the past during childhood. You know, otitis media with effusion is very common in childhood. Eustachian tube dysfunction is common also in children. So learning from the past experience, the brain learns, that is, the low frequency hearing loss from otitis media feels as ear fullness. That's why whenever you have a low frequency hearing loss, sensory neural or conductive, that's why it's very common to feel the ear fullness. So it looks interesting explanation. Speech discrimination in Meniere's disease. So let me to ask the audiologist here, what's your experience about speech discrimination in Meniere's disease? Do we have audiologists? Yes. So what's your experience? What is the speech discrimination scores you got from Meniere's disease patients?
Sir, invariably it correlates with the degree of hearing loss. So if you have, say, for example, moderate hearing loss, you will get scores of around 80%.
That makes sense. That's yes, Dr. Manoj.
Expecting commensurate with the hearing loss.
Thank you, Dr. Manoj. Any other comments? You want to comment? So, both of you are right. This is what have been reported, that it can show very excellent, better than expected speech discrimination, and they called it like cochlear conductive hearing loss. And in other reports, they reported really they have more worse speech discrimination. And I read this myself. So some reports, they have much better speech discrimination than the degree of hearing loss. Some reported they have the same expected speech discrimination scores from the degree of hearing loss. And some reports, they reported they have much worse or poor speech discrimination. And this is simply because that is the pathology in Meniere's disease can have different extent and different lesions. So if just it's endolymphatic hydrops with a sparing of the hair cells, usually you can expect much better speech discrimination scores. And if the hair loss started to occur, it will cause speech discrimination scores matching or appropriate to the degree of hearing loss. But when the disease process spreads to the neural structure, the spiral and the scarbus ganglion, in this case, you expect they got a much worse hearing speech discrimination scores. So all the answers are right. It's a spectrum, so there is no exact or specific pattern. You can get expected speech discrimination score, you can get a better than expected speech discrimination scores, or you can get a worse speech discrimination scores. One of the characteristics of Meniere's patients hearing loss, frequently they do have recruitment, sometimes not happy with the hearing aid fitting. This is mainly because they do have a very bad recruitment. And for the audiologist fitting hearing aids, for Meniere's patients, you have really to consider the uncomfortable loudness levels, and you have to sit them very well. Sometimes you have to change the maximum power output of the hearing aid. So always consider the recruitment and the narrow, very narrow dynamic range in Meniere's patient when you want to fit them with hearing aids. That's a common concern. Lab test in Meniere's disease. So how frequently you request lab test in Meniere's disease? Dr. Manoj does not request lab test. Any others? Okay, so it's recommended to one of the differential diagnoses of Meniere's disease to have immune-mediated inner ear disease. Otosyphilis is another differential diagnosis of Meniere's disease. In Middle East, otosyphilis or syphilis generally is very low. So what is about India? Very low, that's good. But in countries like the United States, Europe, syphilis and the Lyme disease, especially Lyme disease in Europe, but otosyphilis is like in United States, it's consider the differential diagnosis of Meniere's disease. And that's why it's recommended to do some CBC, ESR, C-reactive protein, and the lab test for the syphilis, and antinuclear antigen for the immune-mediated inner ear disease. And the Lyme serology is recommended in Europe because Lyme disease is common in Europe, and sometimes it mimics Meniere's disease. So at least the CBC, ESR, C-reactive protein, and ANA test. Vestibular testing in Meniere's disease. The goals of vestibular test in Meniere's disease is first to address the status of the peripheral vestibular system, to address the status of the other ear vestibular function, to assess the general balance ability in between the attacks, to rule out central vestibular deficits, and for monitoring of treatment, especially with gentamicin and vestibular neuroectomy. So vestibular testing in Meniere's disease, important to do video nystagmography to record spontaneous or positional nystagmus. Caloric test with video head impulse is, would be of diagnostic value, because if you find weak caloric test and the normal video head impulse of the same lateral canal, it's specific to Meniere's disease, according to what the Australian group McGrive and Courtois published in 2015. And they explain this because that the caloric weakness is not due to a sensory loss or hair cell loss, but it's just because of the mechanical dilatation of the semicircular canal. It changes its ability to generate convection currents, and that affects the heat transmitting mechanism, and it does not allow the caloric stimulation. But it's not because of the loss of the vestibular function. So if you have this dissociation between the caloric test and the video head impulse test in the same ear, think about Meniere's disease. Electrocoagulography. How frequently you do electroecog in Meniere's disease? You do ECOG for Meniere's disease or not much? Not much. Why? That's a very good reason. So it has low sensitivity, low specificity. That's true. The test, although it's a little popular, but its sensitivity, specificity does not exceed 70%, 60 to 70%. It can be used as an add-on value test, but you cannot build in base your diagnosis in the electrocoagulography. But it can be add value test. In our experience, we have the opportunity to do ECOG for Meniere's patient during the acute attack. So interestingly, the SCP-AB ratio was up to 100 or more. So you have very two prominent peaks, one for SCP and AP. So my personal belief that is, it's really if there is like an acute attack, or there is sometimes, especially in the acute attack, the sensitivity of the test goes very high. And as a protocol in our institute, we do always ECOG before the gentamicin injection. It's not very specific in Meniere's disease. It can occur with perilymphatic fistula, superior canal dehiscence, and it's not very sensitive except during the acute attacks. And we have like 3-4 cases we tested during the acute attack. So it was the SCP-AB ratio. It was 100 or around 90 to 105%. So we have like a very clear abnormality. Vestibular evoked myogenic potential, including frequency tuning. That's a good test, and there is many current publication on the importance of the frequency tuning shift in Meniere's disease. So ideally, or normally, most of the normal individuals, they got a wonderful or very robust responses for VIMP by 500 Hz tone burst. But they do find in those with Meniere's disease that the best response does not come from the 500 tone burst. It comes from a higher frequency, like 1,000 or 2,000. So it's mainly 1,000. I think some studies going on in All India Institute of Speech and Hearing. This is almost maybe a very specific sign to Meniere's disease. So this frequency tuning shift, and I think they developing a very good algorithm to in All India Institute of Speech and Hearing. They test simultaneously different frequencies, so it takes a shorter time, and it's very, very specific. It has a higher specificity, much more than the ECOG for Meniere's disease. So the frequency tuning shift. So you do 500 or 1,000 at least. Then when you don't get a good response for 500 and you got a better response for 1,000, that suggests Meniere's disease. Imaging of Meniere's disease, and I quoted the first sentence from Dr. Manoj. Actually, every patient with Meniere's disease with unilateral sensory neural hearing loss, tinnitus, vertigo, they should get an MRI. Yesterday, it was only MRI, but I added with gadolinium enhancement, because really I agree with him. Sometimes very small vestibular schwannoma sometimes will present like Meniere's disease, and it will be missed if you didn't use contrast. So really, it's worthy that every case you suspect Meniere's disease, you should get an MRI with gadolinium enhancement. And the criteria for diagnosis of Meniere's disease necessitate that you have to exclude other causes. And if you didn't get an MRI, really, you can't exclude other causes. There is interesting protocol coming that they do MRI with intratympanic gadolinium enhancement, especially the Japanese groups, the Japanese researchers, I think, published a few articles on this, and it showed very clear the endolymphatic hydrops and the extent of changes in Meniere's disease cases. Yes, Dr.
Proven.
That's a good point and should be addressed. That's a good point and should be addressed. It's something new. I don't have personal experience, and there's a number of published papers is not still quite few, but it's something promising. At least before you go, most of those ears with suspected Meniere's disease, they do already have hearing loss. They do already have vestibular dysfunction. So you don't expect much damage from the gadolinium. The ear is already damaged to some extent. But this is an important point and should be addressed. And it's something new, but it gives a new insight that you can accurately assess the endolymphatic hydrops. The image they got is really very clear, and sometimes they use reconstructed image, computer reconstruction of 3D and all these advanced technologies, which makes really the diagnosis of endolymphatic hydrops, anatomical diagnosis and the imaging diagnosis, it makes it very easy. And I think this will improve the current evidence and the current knowledge on Meniere's disease, because you have very precise, objective way to assess the presence of endolymphatic hydrops. Interestingly, one of those studies, they correlated the MRI with gadolinium, with the intratympanic gadolinium finding with the caloric weakness. So their findings supported the Australian group speculation, that is the endolymphatic hydrops causes the caloric weakness just because of the heat transmission mechanism and because of the dilatation of the semicircular canals. Most of those patients with caloric weakness, they showed endolymphatic hair drops with this protocol of imaging. So I think that could change in the future our understanding of Meniere's disease. Just I quoted this image. Even they do some classification based on the imaging. So it seems that is in the near future, I do expect that imaging techniques will be incorporated into the management and diagnostic protocols in Meniere's disease. So all of you are aware of the diagnostic criteria of American Academy of Otolaryngology. It has been published in 1995. And I think they will release the updated one next year. We tried to get it, but we couldn't. But it's on the review process. And next year, they will release the new guidelines. So we are not very happy that you have many categories. That will make it for clinician little hard to comfortably diagnose Meniere's disease. Barani Society, and if you are not aware of Barani Society, this is a balanced society. It includes a neurologist, otolaryngologist, scientist, audiologist, physical therapist. So they got all the professionals involved in the balance testing and management in one society under one umbrella from all over the world, and they are trying to do consensus documents on diagnostic criteria and on management protocols. I think they are doing a great work in the last 10 years, and they have been successful to issue many. Most of their documents are free. You can access just to go to Barani Society, Journal of Vestibular Research. You will find all their documents. I do recommend to read them. And they put a strict criteria for the consensus that different specialization has to be included in the committees from different, at least 3 continents in the world. So just trying to agree for all these topics with controversies. So the end users or the clinicians, they have one consensus document. So I recommend reading their publications. So they put a new classification, either definite or probable. And they put, as you see, 2 or more spontaneous episodes of vertigo, each lasting 20 minutes to 12 hours, audiometrically low to medium frequency sensory neural hearing loss in 1 year, defining the affected ear on at least one occasion during or after one of the episodes of vertigo, fluctuating oral symptoms, hearing loss, tinnitus, or fullness on the affected ear, not to be better accounted by another vestibular disorder. Probable Meniere's disease, 2 or more spontaneous episodes of vertigo, each lasting 20 minutes to 24 hours, fluctuating oral symptoms, and not better accounted by another vestibular disorders. So, putting these diagnostic criteria in mind, you have to do differential diagnosis of Meniere's disease, especially with other conditions. And the most common differential diagnosis of Meniere's disease is vestibular migraine. Prosper Meniere himself, he suffered migraine, intractable migraine. And one of his French published articles, I have the article, here he reported that he believes that most of the Meniere's symptoms, or of the Meniere's disease symptoms, is caused by migraine or related to migraine. So this is association between Meniere's disease and vestibular migraine is no doubt, it's a fact. It's very common, and it's sometimes you don't know which of it. So it just should be kept in mind. Look for vestibular migraine in each patient. So in your experience, how frequently you see hearing loss with patient with vestibular migraine? Or whenever you see hearing loss, immediately you diagnose the Meniere's disease and exclude the vestibular migraine. vestibular migraine can cause hearing loss and can cause different degree of hearing loss. Yes, of course, not aggressive and not progressive like Meniere's disease, but it's reported, and now there is more growing evidence that migraine can cause hearing loss with different mechanisms, vasospasm, something, whatever, but it can cause different configuration of hearing loss. In most of the cases, it's a mild degree of hearing loss. Yes, ma'am. Yes, even tinnitus, ear fullness, pain, ear pain, tinnitus, fullness can occur with vestibular migraine. Vestibular migraine is a big entity, not fully understood until now, but there is a lot of trigeminal nerve involvement. All the structures innervated by the trigeminal nerve, they can get some sort of symptoms during the vestibular migraine. So it's not uncommon to have like facial pain, to have ear pain, to have even lacrimation, irritation. Dr. Solara, she put a slide yesterday about the computer vestibular syndrome or the computer vision syndrome. And I told her, I don't believe that is new. That's all comes with migraine. Because if you don't know, migraine can cause ear pain, it can cause facial pain, it can cause lacrimation, irritation, all through the trigeminal pathway. Because there is very strong involvement of the trigeminal nucleus in the vestibular migraine. So hearing loss it can be, but it's always not following the exact configuration, the low frequency with progression to flat. It's always mild degree, and sometimes it's of more severe degree because of the vascular occlusion due to the vasospasm. But presence of tinnitus, ear fullness, hearing loss does not exclude vestibular migraine. Vestibular schwannoma, it can be presented by unilateral tinnitus, sometimes vertigo, tinnitus, which should be ruled out by MRI. Otosyphilis, it can cause a picture similar to Meniere's disease, maybe with more bilateral affection, with more profound degree of sensory neural hearing loss. Immune-mediated inner disease, sometimes a differential diagnosis like in 6-7% of the cases, sometimes with bilateral affection. So at least you screen in the history for other immune-mediated diseases, systemic lupus, or rheumatoid arthritis or something, and you can do simple screening by the antinuclear antigen. Perilymphatic fistula, always look in the history for restraining recent flights, diving or something, because they can also present by hearing loss, fullness, and vertigo. Metabolic autosclerosis or autosclerosis with secondary like endolymphatic hydrops, that it's not very rare. Sometimes patients with autosclerosis, they do have vestibular symptoms. A natural history of the Meniere disease, longitudinal studies have shown that from the time of presentation, approximately 70 to 80% of the patient are free of symptoms at greater than 7 years, regardless of whether there have been an intervention or not. So it's the natural history that vertigo will burn it out. Treatment modalities in Meniere's disease, it was based on the theoretical pathophysiology. The salt restrictions comes from those researchers in 1932 who associated the Meniere's disease. It's like some sort of angioneuritic edema. So they recommended the salt restriction. The Meniere disease was based on one of the theories that that the middle ear pressure can influence the middle ear disease. And because of the theory of endolymphatic hydrops, they proposed the diuretics as a treatment modality. And because of the other theory which reported explained Meniere's disease based on the labyrinthine vasospasm, vasodilators came out. So To understand the treatment modalities of Meniere's disease, you have to well understand the placebo effect. And the placebo effect is defined as specific beneficial response elicited by the administration of a non-specific or an inert intervention. And the two basic mechanisms have been identified for the placebo effect. First is the expectation of cure in situations involving conscious physiologic process, especially those like pain or perception of motor function. And the second, a conditioned response, is the more dominant mechanism in unconscious physiologic process, like immune-mediated or hormonal secretions. Functional MRI and positron emission tomography scanning, EEG studies showed that the placebo activates the same neural pathway as the active treatment. The high placebo response rates, together with the fluctuating natural history of the disorder, necessitate larger number of patients in any placebo-controlled study of the treatment efficacy. So when you read the literature of Meniere's disease, always look to the methodology. Many published treatment modalities, they take the patient as a control himself, and they just do follow-up through 2 years. This is a completely flawed methodology. So ideally, it should be a placebo-controlled study with a large number of subjects. So be careful, because sometimes reanalysis of the published articles gives a completely different results. The vast majority of studies of potential treatment for Meniere's disease are not placebo-controlled. A therapeutic efficacy up to 80% can be expected from a placebo treatment in short-term outcomes, and 60% in long-term outcomes, which means at least 5 years of follow-up. So any scientific background for the placebo effect? Yes, it's mediated through the CNS, through the neuroendocrine system, effect on the steroid receptors in the cochlea and stria vascularis, and through the autonomic nervous system, effect on the vascular beds in the inner ear, and through the efferent neurons. So what is the ideal placebo? It should carry minimal risk of side effects. It should carry a minimal financial burden, not adversely affect the quality of life, should be abundant for more specific treatment if the patient response is not good enough. So dietary restriction, there is no study which provides convincing evidence for salt restriction role in Meniere's disease. Nonetheless, a low salt diet continues to be widely encouraged. Most regimens call for a daily sodium intake of less than 2,000 milligrams. A common sense low salt diet is an example of placebo. In addition to restricting salt, restricts the intake of caffeine, chocolate, cheese, and alcohol. And all these dietary restrictions, it's actually used for the prophylaxis of migraine. Vestibular suppressants and antiemetic agents are used to control acute vertigo attacks. All of these drugs have varying degrees of anticholinergic, antiemetic, and sedative properties. So different drug groups like the antihistamines, sedating antihistamines, anticholinergics, and the benzodiazepines can be used. Benzodiazepines have an additional beneficial anxiolytic effect, but it has a drawback that dependence or habituation is very high. No strong data currently exists to support one abortive regime over the another. In our, we use sometimes the meclizine, 60 milligram. We use dimenhydramine, 50 milligrams to abort the attacks. Diuretics. To date, diuretics are the most widely used pharmacologic agent for the treatment of Meniere's disease. The theoretical basis for their use is to diurese the inner ear, thus relieving the excess fluid volume associated with the endolymphatic hydrops. 4 main groups of diuretics have been investigated: thiazide diuretics, potassium-sparing diuretics, loop diuretics, and carbonic anhydrase inhibitors. Strong evidence to support the benefit of diuretics is lacking. An early double-blinded clinical trial by Klokov comparing hydrochlorothiazide to placebo showed significant improvement in vertigo and the quality of life and hearing in the treatment group. Reanalysis of the data showed seriously flawed methodology and invalid conclusion. Vasodilators, they are presumed to function by improving the cochlear microcirculation, although some studies have demonstrated the beneficial effect of beta-histine in patients with Meniere's disease. The overall strength of such data is weak. Some have suggested that the use of vasodilators in Meniere's disease is counterintuitive. They showed that increasing the blood flow to the stria vascularis would increase the endolymph synthesis and secretion, which would worsen the condition. It's also seemingly logical to treat patients with beta-histine when antihistamines are used to abort the attacks, especially to... Yes.
Could I add, one of the counter suggestions to this is increasing vascularity improves absorption and therefore reduces endolymphatic hydration.
That's correct. It's all just on theoretical basis. And personally, we use in our institute, we use beta-histine. It's a safe medication, well tolerated and not very costly. We don't know if it has action or just the placebo effect, but we do use it. At present, there is no evidence that the efficacy of vasodilators in the treatment of Meniere's disease exceeds that exhibited by placebo treatment. Non-selective drugs such as beta-histine is inexpensive, unlikely to adversely affect the patient quality of life, and carries a low risk of side effects. Therefore, beta-histine's use can be justified as patients may benefit from its non-specific therapeutic effect. Minute device. Anybody has experience with minute device? Yes, Dr. Manish. Stop. So it doesn't work. Yeah. Okay. That's based on some theories that the middle ear pressure can affect the inner ear, and it's very expensive. I have no personal experience with it, and there is no evidence that it works more than a placebo. Surgical treatment in Meniere's disease. The majority of patients who suffer from Meniere's disease can be managed successfully using a medical regimen until burnout. No clear definition of the medical failure. Approximately 10% of patients with Meniere's disease require a surgical intervention. Surgical and conservative bias has a role in timing of surgical infection. So surgeons, they usually bias to do more invasive procedures. Other specialties who don't do surgeries, they are biased towards not to use the invasive procedures. Many surgical interventions, there is many surgical interventions, and it's believed that if there are multiple ways to treat a disease, there is no good one. Because if we have a method of treatment with great efficiency or great success, it will be the standard of practice. So for surgical interventions, there is two types. There is cochlear function sparing interventions, and there is other interventions which could affect the cochlear function. So those with cochlear sparing intervention include the intratympanic steroid injection, the intratympanic aminoglycoside injection, and the endolymphatic sac surgery, and the vestibular nerve section. So regarding the intratympanic steroid, the diverse study design short-term follow-up periods make it difficult to draw any strong conclusion about the intratympanic dexamethasone treatment for Meniere's disease. Intratympanic dexamethasone represent a well-tolerated low morbidity procedure. Vertigo controlled rates for dexamethasone are approximately equivalent to what one would expect from a placebo. Dosing regimen should include multiple injections with repeat injections at the time of occurrence. Intratympanic aminoglycosides, the overall treatment goal for using this treatment is to eliminate vertigo while preserving hearing. Different dosing regimens have been used to maximize vertigo control while minimizing the complication of hearing loss. Continuous infusion through a pump, multiple injections through a catheter, weekly doses through ventilation tubes, regular interval injections, and single dose aminoglycoside injection can be used. Intratympanic gentamicin offers complete or substantial vertigo control in better than 90% of patients for a period of 2 to 5 years or more. An increase in hearing loss is noted in approximately 25% of patients. However, the magnitude of this hearing loss is small. Titration strategies in which the injections are discontinued with evidence of an effect of the drug, either new onset of hearing loss or vestibular loss, appears to maximize the vertigo control. So using titration strategies improves the outcome of gentamicin, for intratympanic gentamicin. Vertigo control rates obtained by intratympanic gentamicin treatment exceeds those expected from placebo. So there is evidence that intratympanic gentamicin helps in the control of vertigo. Imbalance after gentamicin treatment is usually transient and can be treated effectively with vestibular rehabilitation. The procedure is performed as an outpatient setting, avoiding the expenses associated with hospital admission. Patients who are resistant to intratympanic gentamicin may benefit from a middle ear exploration to eliminate any anatomic obstruction that prevents the drug from accessing the round window membrane. That looks something theoretical. So and that small subset of patients whose vertigo recurs quickly despite the gentamicin treatment, a more aggressive surgical treatment is indicated. Endolymphatic sac surgery, in fact, Schukenschmidt included or concludes that the endolymphatic shunt surgery.
So we have time on this thing.
Yeah,
so
2-3 minutes. Okay, sorry for this.
Sorry.
No, it's fine. That is as one of his myths of neurotology. So shurgeries involving the endolymphatic sac are broadly divided into endolymphatic sac incision, subarachnoid shunting, mastoid shunting, and decompression. We'll skip this because interesting study done in Finland. It's called the SHAM study, where they did controlled study with a group of patients with active sac surgery and the placebo mastoidectomy arm of the study. So one arm, they did the sac surgery, and the other, they just did mastoidectomy. And the finding was that a placebo surgery can result in a resolution of symptoms of vertigo in close to 70% of patients, which is a truly remarkable finding. So even the surgery can work through a placebo effect. Vestibular ablative surgery for Meniere's disease, surgical results will only be as good as surgical indication. So you have to select the right candidate for surgery. It's critical that the patient being considered for a vestibular ablative therapy carry a diagnosis of Meniere's disease. You have to get sure that the patient already has Meniere's disease. Vestibular nerve section. Vestibular nerve section offers an excellent method of controlling vertigo while preserving hearing. Different approaches with different surgical complications. Labyrinthectomy is preferred in patients without serviceable hearing in the affected ear, as it carries slightly less risk of complication. A properly performed transmastoid labyrinthectomy ensures the complete ablation of the vestibular endo organs. Labyrinthectomy should control vertigo in at least 95% of the cases. Significant postoperative disequilibrium is seen in majority of cases, and this is usually well addressed with vestibular rehabilitation therapy. Failure to control vertigo might result from an incomplete labyrinthectomy, bilateral disease, or associated migrainous vertigo. Adjunctive therapy, vestibular rehab therapy, and cochlear implantation. Just 1 minute, we'll talk on vestibular rehabilitation therapy. Traditionally, it was known that is vestibular rehabilitation therapy not recommended in Meniere's disease, but in the last 20 years, there is growing evidence there is a need for the vestibular rehabilitation therapy. Because there are many indications of vestibular rehabilitation therapy in Meniere's disease. If there is associated benign paroxysmal positional vertigo, if you have uncompensated vestibular lesion from progressive labyrinthine dysfunction, in case of bilateral vestibular loss, pre and post gentamicin injection therapy, pre and post ablative surgery, and the general functional balance disorders. So the goals of VRT and Meniere's disease to decrease or eliminate the dizziness and vertigo, improve the gaze stabilization and visual motor control, improve tolerance to motion, improve functional and balance safety, increase activity levels, reduce falls or risk of falls, increase the functional independence at home work and in the community. Contraindication, if there is only spontaneous acute vertigo attacks with completely normal, symptom-free in between the attacks. A psychological attribute of Meniere's disease that's important because the stress personality trait, tension-driven and self-inhibited personality traits are more common in patients with Meniere's disease. Stress as a possible cause of the illness or trigger of the recurrent attacks should be addressed and should do some stress management procedures. Psychiatric disorders such as anxiety, depression is common in Meniere's disease, and we studied this 12 years ago, and there is more incidence than the general population of anxiety and depression in patient with Meniere's disease. Quality of life in patient with Meniere's disease, poorer quality of life was related to more severe vertigo, hearing loss, tinnitus, and pressure in the ear. So treatment of psychiatric morbidity in patients with Meniere's disease is important. We have to understand the effects of psychological factors on medical and surgical treatment of Meniere's disease. And anxiety has a negative effect on functional levels in patients with Meniere's disease, and they may exert an adverse effect on the outcome of common medical and surgical treatment. And anxiety and depression can be adequately treated in patients with Meniere's disease, resulting in improved physical and mental outcome. Thank you.
Thank you.